Thank you, Arizona Trauma Association, and Dr. Mangrum for allowing me to be here. It's an honor. So I was going to talk about cervical spine clearance and just kind of talk about all the things that we do know and what we do, but when I was asked to actually create the guideline, a practice guideline at Banner University, what I came across was there was literature to describe certain things, and then there was literature that did not describe things, and there were a lot of questions that I had to work through and work with a panel of experts at our facility and the trauma surgeons in Tucson, and I kind of wanted to talk about that because I thought that might be very interesting for everybody. Okay, so my talk is Conundrums in Cervical Spine Clearance. I don't have any disclosures, and my objectives are to talk about evaluating the cervical spine of an obtunded patient, specify the degree of degenerative disease when you are describing what a normal or negative CT scan is, evaluate a patient with a negative CT, but the provider still has a very high index of suspicion for clinical injury, and assess cervical spine tenderness and what to do when it's persistent despite a negative workup. So there's no controversy about what we do well. Identifying the patient at risk for a cervical spine injury, we know what we look at. We look at mechanism, high motor vehicle speed, motorcycle collision, ground level fall, axial loading, we got that. Neurologic deficit, makes sense, obviously. If they have a neurologic deficit, they're not moving their extremities, these things will alert us there might be a cervical spine injury. And then if the patient has cervical spine tenderness with palpation. Sorry. What we also do very well is clear the cervical spine clinically when we can use these two. The first one is Nexus Criteria, which allows us to determine whether there's a high probability for a cervical spine injury. If they don't have any of these 5 criteria here, then you can clear the cervical spine easily. And this is a validated tool that we can use. Some folks don't like the Nexus Criteria and they like the Canadian cervical spine rule, which is equally as validated and reliable. And this one just kind of asks a couple of questions in terms of high risk factors or mechanism, and whether the patient can actually do range of motion on their spine if there's a low a suspicion or injury. And you can also clear the spine with these two. But what do we do with the obtunded patient? And this is one of the most controversial things that is, I would say, debatable amongst my own practice and also nationally. There's been actually a multi-institutional, multi-review trial from the Journal of Trauma and the East Guidelines in February 2015 that actually looked at this. How do you clear a cervical spine in an obtunded patient? And the first thing you have to do is define what is obtunded. And just off the bat, even this is the most controversial thing because nobody can agree on it. It was author specified or provider specified. Is it GCS less than 15? Is it altered mental status? Is it they're intoxicated, degree of intoxication, you name it. So in our practice, pretty much if you're not awake or alert, we will consider you obtunded. The definition, I don't think I've seen anybody even try to actually sit there and validate what we define as obtunded. So it's very much provider specific. And then, so you can't clear the spine clinically on your patients either using Nexus or the Canadian cervical spine rule, and you have this patient that you're considering to be obtunded. So how do you screen for a cervical spine injury? What is the best imaging modality? So x-rays. X-rays have actually fallen out of favor just because they're not as sensitive. And with how well our CT scans now have become more accurate, they're with the slices, the multi-detectors, we have actually become more reliant on the CT scan. But this is where the controversy starts. How sensitive is the CT scan for ruling out a significant clinical injury? And it depends on what literature you read and what actual department. I've been very fortunate to, when I've been working through this guideline, to work with my trauma surgeons, the neurosurgeons, the spine surgeons, the orthopedic surgeons, and the radiologists, and they all bring their literature together. And I would say that the trauma surgeons are the ones that have actually gone out with the most kind of controversial and drag-on fights about this CAT scan. The CAT scan is 98.5% sensitive in terms of ruling out a ligamentous injury, and it's 100% negative predictive value for unstable injuries. And that being said, I would say that for our practice, a CT scan is really good. It will be able to tell you if there's an unstable injury, and it will be able to tell you if there's a 98.5% chance that there might be a ligamentous injury in your patient. But that being said, there's still that 1% of patients that might have an unstable injury or a ligamentous injury that had somebody described as having devastating effects that was missed, and that 1% is where this big controversial argument comes about. Should we MRI everybody? And as you know, MRIs have their pros. Sure, you can add an MRI on and you will probably rule out most injuries, but what about the cost? What about the travel? And there are stories of folks that have actually gone down to the MRI machine, coded, and died. So there's arguments to both sides. And what we found to be in our practice with everything that we've discussed is that for us, we can reliably use the CT scan if it is negative, and I will talk a little bit more about what negative we have specified negative as, to be a good enough test to screen that there's probably a not a ligamentous injury and an unstable injury, and again, that the collar, even if that 1% of injuries might be missed, a collar is not going to help it. And if you look at the literature, actually, that 1% is sprains, strains, and if they are injuries, they don't need a collar. So does a normal CT scan include degenerative disease? This is also another question that came up while we were doing this guideline. So define what is a negative CT scan. I think this is where you need to work with your radiologist, because you need to identify three things, and in our protocol, that's what we did. No bony abnormalities, spinal alignment must be visualized, and it actually has to be normal, and there has to be no soft tissue edema. And then there's the issue of the degenerative disease, and what severity of degenerative disease is actually considered normal. In Arizona, we have a lot of ground level falls. We have a lot of older patients. They all have degenerative disease. So there's no grading system, actually, but the radiologists have defined, based on what they look at, if it's mild, they consider it normal. So you have a negative CT, but you have still a high clinical index of suspicion. So your CT is pretty good, but you have a patient that you're still worried about. And why are you worried about it? Provider discretion is something that we've included in our guideline. This is the patient that maybe they weren't moving all extremities when they came in. Maybe the clinical exam doesn't match the imaging exam. Maybe there is something there that is still making you concerned over this patient possibly having an injury. This narrows it down quite a bit, because this might not be everybody, and so this kind of narrows down your MRI need. And so if you do still have that high clinical suspicion, then you can MRI that patient. The other thing that we discussed is, when do you consult your spine surgeons? And I think, again, this is something that you need to work with your spine surgeons in your department and see when they would like to be called. Would they like to be called right away? Would they like to wait to see what the MRI shows? And our spine surgeons actually, since we get a lot of transfers from outside facilities, are very used to being called anyway. So they don't mind. If you have a question, if you're concerned, they will evaluate the patient. What the last topic was persistent cervical spine tenderness with a negative CT. You have three options. You can leave them in the collar and you can observe them. And what do you do? Maybe you observe them overnight, 2 weeks, 4 weeks, 6 weeks. Again, not very well defined. And it's really based upon your practice. I usually will observe these patients. I'll re-examine them in the morning if they have especially if they have a negative CT. And most of the time, the patients will resolve, whether it's the pain or whatever else that they're having. If they continue to have it, it's 2 more weeks, and then we actually go ahead and re-examine them, reassess them in our clinic. Some folks tell you go ahead and get an MRI, also reasonable. And then there's the other imaging of flexion extension, which a lot of spine surgeons will use on an outpatient basis. But if you look at the literature, it doesn't really add much more if you already have a negative CT of your cervical spine. So what is our practice? In an obtunded patient, a negative CT scan alone can clear a C-spine. Create internal consistency in defining what a negative CT. I think this is really important to work with your radiologist as well as your spine surgeons. Create clear indications of an MRI after a negative CT. This focuses it so you're not ordering MRIs for everybody. And a multidisciplinary approach and support, I think, is key here. I just included also our guideline. It's obviously very difficult to see, but I'm happy to answer any questions or if you have any comments. Thank you.